Welcome back to the Doc and Diana Show. I am Doc.
And I am Diana.
So happy to be back today, and we're talking a little bit more on that cardiovascular disease thing.
Hard hands.
It makes me think of that commercial.
Oh.
Sunset Hard Hands.
Yes, take my picture.
Okay, so today I wanted to talk a little bit about a study that I just reviewed, and I put the post on the website. And I've seen so much data along these guidelines or along these parameters with this kind of thought in mind that I was like, this makes absolute sense. And we are formulating a really cool, really novel way of testing or screening, I should say, for cardiovascular disease and seeing, am I going to have a heart attack or not? And my experience, there was a patient that I was still in the military, active duty military, and I had a patient one time. I was working in the hospital. This was just before I got off active duty and came back to Tulsa. And this patient came in and he said, I just wanted a physical. I just wanted to, just make sure I'm healthy. And I remember looking at him thinking, I don't know what to do for you. Like, what do you want me to do? I mean, I can listen to your heart, listen to your lungs, and it sounds good. I can get some basic labs, but I mean, the guy was like 30. He wasn't 70. So it's like, what do we do? We're going to do some very basic things. So, like, if you wanted to go to your doctor and wanted to get your heart checked, what would you do?
Well, I'm like you. Like, if I were to go in and ask, I would expect them to listen to it. Make sure it's not beating crazy and doing stuff, that it's like rates great, no weird noises. I know they're gonna ask me questions. Do you get out of breath walking upstairs? Those kinds of things, but I wouldn't know what else to expect. I don't see myself at an age where they're throwing me on a treadmill and do a stress test.
Right.
They're gonna ask me about family history.
Mm-hmm.
They're gonna check my normal parameters, like my weight, like what's my BMI. They're going to ask me about my lifestyle choices. They're going to ask me, like, do I smoke? Do I drink? They're going to ask me that. But I wouldn't imagine them, a typical physician, asking much more than that or doing much more than that.
Yeah, so and you're basically right. Now, most of the time, they'll probably say, well, let's go ahead and check your cholesterol, and let's check your blood sugar, and that's a maybe. I don't even know if you meet criteria to check your blood sugar.
Well, they're not going to do anything insurance isn't going to pay for, so
Right.
let's just
Right.
nip it in the bud there.
So, I mean, you're not going to get much.
Yeah.
And so there are some screenings that you can get, like there's a Lifeline, Lifelink, something like that, some screening company, and you can call them, and I think they've got some decent stuff, but they'll ask you the same kinds of questions, and they'll say, okay, well, we can do some screening. And I've got some issues with the kind of screening that they're using, and I don't mean to pick on any one of them. I think they're doing some good things. I just think we can do it better, and that's my whole issue. So what we're looking at are risk factors. So if you go to your doctor, they're going to measure your height, they're going to measure your weight. So they're going to calculate your body mass index, and they'll look at, are you normal, overweight, or obese? And that categorization has some data behind it. They're going to look at your blood pressure, and I'm all over that one.
Mm-hmm.
But in my experience, I don't think we define hypertension appropriately. We as in traditional medicine, certainly not the way I was trained. I don't think we're aggressive enough. We need to get blood pressure down as much as we can to less than 120 over less than 80. We've got a video about that. And whether it's medications, lifestyle, traditional Mediterranean diet, the DASH diet, I've got posts about all these on the website, revolutionhealth.org. Any of those things, but all they're doing is looking at risk factors. Your cholesterol, is your cholesterol high? That's a risk factor. You can have high cholesterol and live to be 120. It does not mean you have disease. It's just a risk factor. And there is association, but not causation. Cardiovascular disease is not caused by LDL cholesterol.
So what's that pharmaceutical that they're going to give me if my cholesterol's high?
A statin.
Oh, that's one of your
Yeah,
favorites.
right. So statins do have some benefit in some patients.
Yeah.
But
it's duct tape now.
It is. It's your LDL is high. We're going to put you on a statin.
Yeah.
It's just this. Here's your problem. Here's your pill.
Yeah.
And that's all it is. So we're managing risk factors. The other thing that they may do is they may calculate a Framingham Risk Score, and in the military, at least in the Army, they will calculate a Framingham Risk Score and determine, do you need this test or not, like an EKG.
They're plugging in all of these pieces that they've asked, the lifestyle, the BMI, my blood pressure numbers, they're plugging weight, all this into this calculator,
Right.
where parameters are already preset,
Right.
and then it will automatically put me into a category.
Yes.
Okay.
And with the Framingham Risk Score, which, by the way, I think is awful, it is.
Do you know how old? I don't mean to put you on the spot. Do you know how old it is? Like how long?
Well, we're in Framingham 4. It started in the 1940s. I can't remember if it was 1940 or 1945. It's the longest running cardiovascular disease risk study. But we're looking at Framingham, Massachusetts, and we're looking at populations, and we're looking at what are their lipids and how are they doing over their lifespan. And so that's kind of where that data comes from. We're on Framingham 4 or something like that now. So it's been going on for a long time, but it's a select population. It's not the global population of the United States. And so we can't say that this data necessarily applies to you.
They don't know me.
Right, exactly. So the Framingham Risk Score is just looking at, based on these parameters, what is your likelihood of having an event in the next 10 years? And they'll put it into percentages, less than 5%, 5 to 10%, those kinds of things. So they'll put them into those categories. Yeah. But it is all based on risk factors. And so it's risk factor screening. And when I look at the medical literature, it is very clear to me that we are missing a ton by simply looking at risk factors. We are missing, in fact, there's literature on this, I've got information on the website about we miss, when we're looking at 5 traditional risk factors, obesity, cholesterol, your lipids, diabetes, and tobacco. If you look at those 5 traditional risk factors alone, again, we're looking at risk factors. We're not looking at disease states. We're looking at risk factors. Right. And we miss 50%. 50% of people that will have a heart attack will not be caught by looking at these 5 risk factors. And one study showed that if you're 50% of the people showing up to the emergency department having a heart attack had an LDL less than 108.
Were they on a statin?
I don't believe many of them were.
So their cholesterol was fine. So like
exactly.
you said, the little bells and whistles would not go off.
Exactly. So that's looking at risk factors. I think we need to be looking at disease states. So the problem is, how do you know who has disease? And that's where this testing that we are coming up with is focused. We're looking at, do you have disease or not? We can measure your risk factors as well.
Well, and this kind of ties into the conversation that you and I had earlier in the week where we were talking about hypertensive states and how by the time it gets there, by the time that blood pressure has gotten to an obvious, okay, now we're saying you are hypertensive, there's been a disease state going on kind of under the surface for quite a while.
For decades.
Before that, symptom is very obvious and in your face.
Correct. And for example, endothelial function and arterial elasticity are 2 of the initial changes, not counting endothelial glycocalyx, but because that's a relatively new topic, we'll have more information about that one. But these are 2 things that will show up very early, and they precede hypertension.
If you know what you're looking for.
Exactly. And so those are things that, for years we've had a research-based way to measure endothelial function. It's what we call ultrasound measured flow-mediated dilation, but it's not clinically applicable. Most family docs aren't going to be able to do that in their clinic.
Does insurance pay for it?
I doubt it.
There you go.
And it's not easy to do, but there are some tests that are very easy to measure. The machines are a little bit pricey, but some, depending on the state, some insurances will cover
Right.
that endothelial function testing, and we can do that at Revolution. We can measure your endothelial function. We can measure your arterial elasticity. So here we're measuring disease states.
And early, like
Exactly.
just get it done early.
So there was a paper published out of is it Minnesota? I think it's Minnesota. The Rasmussen Center for Cardiovascular Disease Prevention. So they put together 10 tests and came up with a score on, and they called it the disease score. They abbreviated it DS in their paper, and I've got this on my website. You can reference that.
Kind of like Framingham.
Kind of, yes.
Okay.
And so, and they're one of their big arguments is they calculated their Framingham Risk Score in their patients, and then they did their screening and calculated their disease score. And they looked at if your disease score, which you can go look at the website for all of the criteria, but if like for example, your blood pressure at rest was one of the things that they looked at, and if your blood pressure was this range, it was 0 points.
Okay.
If it's this to this, it's 1 point, and it's above 140, it's 2 points. And so they did that with each of these 10 tests that they did, and so you could get a score of 0 to 20. And if your score was 0 to 2, they considered basically no evidence for disease, or there was no disease present in that group.
Okay.
Or a score of 3 to 5 was
Really?
kind of an early disease score, and anything 6 or more was considered advanced disease. And then they followed them for years and saw how they actually did. Did they have an event? And an event was defined as heart attack, stroke, CABG or coronary artery bypass graft, stent, anything related to cardiovascular disease or some kind of intervention because of cardiovascular disease.
Okay.
And then they kind of calculated this out. In 6 years after they did the screening, if your score was 0 to 2, there were 0 events, none. There was one patient that had an event at 8 years that was in that initial 0 to 2, had an event at 8 years, but his score had gone up to 7
On their calculation.
on their calculation. And so that gives a pretty good, if your score is 0 to 2, pretty good indicator that you are very low risk for having an event. Exactly.
I'm not even kidding. Like, stop looking at the risk. Like, you can't ignore them.
Right.
You have to look at the risk factors.
Sure.
But you cannot ignore
The disease state.
state.
So then let's take that same population, and they calculated Framingham Risk Scores. And their Framingham Risk Scores in the group that was considered low risk by Framingham Risk Score,
Okay.
they did not qualify for preventive therapy. They were not identified as saying you're at risk, and so we need to put you on a statin, or we need to do any of these things. So you would just watch them. And more than 10% of events had a Framingham Risk Score putting them in the low risk group. And so when you look at disease state versus risk state,
Now I want to know those people, and I want to know what their disease state was, and where were they on the Rasmussen. Like, I want to track them down.
and that's actually in that paper.
Sweet.
All of those, there's graphs for it. It just goes,
Well,
we
I'll
can
let
talk
you
for hours
translate.
about
I'll
it.
let you translate that another time to me.
So if you were in the higher risk group, that's where most of the events occurred, and I'm talking about the Rasmussen score. So the Rasmussen score, I believe, is a very good test indicator of cardiovascular disease state and risk for having an actual event, a heart attack, a stroke, a bypass graft, a stent, something along those lines. And Framingham Risk Scores just do not have the same discriminating ability. In other words, they are not sensitive enough about picking up the low risk patient. If you're high risk, those scores can do well, and they will catch the ones that are high risk. But it's the low risk ones. And the thing is we see it all the time. In preparation for this, I was looking at YouTube, and I wasn't even searching for this, and it was just on the feed that there was a guy named Chad. I can't remember his last name. He's was a sports broadcaster in, I think, Springfield, Missouri. That's what it looked like. 39 years old, had a heart attack. And he was talking about his stuff. There were case after case after case of young people
So young.
not having any idea and having a heart attack. We have got to be more aggressive about this, and we can't just rely on risk scores,
No.
looking at risk factors. We've got to look at disease state.
And the more toxic our world becomes, the more people are going to be at risk just because it's just overloading and inflammation and
Right.
just lifestyle and things.
Right. And when you look at age and gender, those are two things we can't change, and they're definitely consistently associated with cardiovascular disease. But one of the arguments is that age, it's not that you're older and it puts you at risk. It's that you've had more cumulative effect
Yes.
of having crappy lifestyle, environmental toxicities, oxidative stress.
And nothing's cleaning out. Like
Exactly.
You just keep and that video is coming soon. We will be talking about your total toxic burden. So we will be talking about that because you got to know what's in your bucket. And
Absolutely.
I mean, now we're talking about the fact that the bucket directly affects heart, your cardiovascular.
Without question. Without question. Anything that triggers an inflammatory response, an oxidative stress response, or an immune response is going to cause cardiovascular disease, including eating crappy food one time. You eat one crappy meal, and there is a window
of response.
where you increase
Yes.
the response period, and that does apply to the cardiovascular system as well. My cardiovascular mentor, Dr. Houston, says that atherosclerosis is a postprandial phenomenon.
Meaning right after you eat.
Yep. And so there are several factors that do that. Your gut health and gut function play into that. Inflammation, oxidative stress, what you're eating. If you're eating high oxidative stress foods without sufficient polyphenols and antioxidants and all of these kinds of things, you are increasing your risk of cardiovascular disease, period.
Okay, so up to this point, we've talked about Framingham, kind of how to, I said that right, correct?
Yep.
So how they are calculating just based off of risk factors.
Correct.
We know that we only really look at the top 5. However, research and different things have shown there's like 400 risk
Right.
factors.
Correct.
So we're like barely the tippy top of the iceberg with using that calculating risk. Now we've talked about this new thing, this I say new to just bringing
Right.
it out. It's been
Yep.
around. But this Rasmussen concept of actually calculating and looking at disease state so
Correct.
that technically we're catching things much earlier. So Revolution Health and Wellness and what you're doing with your passion with cardiovascular disease, how close are we to implementing and being able to take care of the patients with this Rasmussen concept and identifying these disease processes at a very early stage so that we can get them on a preventative track and get their lives turned around to avoid
Right.
cardiovascular disease and all the things associated, cabbage,
Yeah.
all that stuff.
So the short answer is we can do it now.
Yes.
And I'll come back to that in just a second.
Okay.
And the Rasmussen score is merely an example. That is not the standard. It is just merely an example. It gives us
Okay.
data. It gives us hard numbers. Here's where your score is, and here is your likelihood. And that's really cool to be able to do that. So that's just an example of one of the many things that we can do to help us better understand your risk of cardiovascular disease. But there's so much more as well. So going back to your question, how ready are we? When I read the original Rasmussen score, they first published in 2003. They tweaked a couple of things, and they published again in 2008, and then they published again 2011, 12, 13, somewhere in there, and it's on the website. Of some of their data. They're coming out with new things all the time. Well, their initial test was this battery of 10 tests. We have the availability to do those now. We can do those now. They since incorporated a screening test because, and this is something that when we first launched our cardiovascular program, it's a little expensive. Now, it goes way beyond what the Rasmussen score does. We're looking at genetics. We're looking at disease state. We're looking at multiple tests, carotid ultrasounds and micronutrients,
Yeah.
toxins, all kinds of things. I mean, it is a broad reaching. To my knowledge, the only other cardiovascular screening that is more comprehensive is Dr. Houston's at the Hypertension Institute in Nashville. I'm not aware of anyone that is doing more broad spectrum testing. And I developed our program, the Revolution program, from my time with him and my education from him, and being able to incorporate that into Revolution. It's taken us a couple of years of doing almost nothing else every evening, going over this stuff and researching, and him, not only him.
I hear his voice, and I can pick it out of a crowd.
Not only him presenting the information and the data, but I have to go back and pull his research, pull his evidence, pull his resources, and I read the actual study of what he's talking about, because I have to understand clearly what he's talking about. And I can't just quote him and walk away. I've got to have the actual real data. He's just assembled it nicely for us. And he's also published quite a bit, so he's got a lot of unique data himself as well. But that initial executive cardiovascular program, which is on the website, that was very comprehensive. My issue is that it was also a little pricey, much more expensive than the original Rasmussen score, which they originally were charging $600 for that, and then they've since changed some things a little bit, but they were originally charging $600 for that.
But you're talking about a screening process.
Yeah, so they implemented a scaled down version that really only checks a couple of things. And if
like an entry point. So,
yes,
okay.
And if you pass these, they don't think you need all these others. So they're trying to keep costs down by getting some introductory tests, and then if you're abnormal on this, then we need to do some additional testing. So what we're doing in Revolution is we're introducing 3 levels of testing based on what does the client want. If they want the full shebang, which I would never argue against, because I don't think you can get too much information, and I don't think you can catch cardiovascular disease too soon. Correct. It's not possible. And I think everyone should do the full program, but not everybody can. And not everybody wants to pay for it or can pay for it. And so it's like, what's a good, just get me in the ballpark. And so we've got our introductory program that we're getting ready to roll out. Yes. It will be out by the time this video goes up.
Awesome.
So 3 simple tests, very cost effective to do it. Takes less than 30 minutes for the whole thing in the clinic. You don't even have to be a patient. You can keep your doctor. You can come get these tests. You don't need to see any of the providers. You come get the test. You walk away. You'll have all of your results in a few days. Some of them you'll get on the spot. Some of them take a couple of days to be read by a radiologist. If those are abnormal, or you think it's cost effective to go up to the next level, we look at peripheral vascular disease. We do EKGs. We do some advanced blood pressure testing. And we start getting some lab work, which we don't do on the initial screen. Okay. Because we want to be able to calculate some of these additional scores to give patients a better idea of how likely is it that I'm going to die of heart disease, or how likely is it that I'm actually going to have a heart attack.
Yeah.
And then the third level is the whole 9 yards. It's just about everything we can do.
Does so even at the third level, a non-Revolution patient can get all that testing, have all the results, and walk away to their own provider.
Sure.
And make their plan of action.
Yes. Now the reason that I would encourage patients to not do that is because even with the initial plan, I was not trained as a family medicine doc, and I would argue that the cardiologists with whom I've discussed these things, they don't know how to read most of the tests that we're talking about.
In the back of my head was just wondering that, so thank you.
Yeah.
Because I'm like, functional medicine, some people think we're weird, and that's fine because it's not the mainstream thought. We get results.
And to be very clear, every single test that I'm talking about is well researched, well studied, well validated in the literature. These are FDA approved devices. This is not some random esoteric, it's not in the obscure Sports Quarterly, the Ocho. It's not in this kind of thing. These are good tests that are just not mainstream.
Right.
Partly because it takes time and it takes education and it takes money to buy the machines. These machines are not cheap, but we've found a way to do it in a cost-effective manner where we can save patients money and get them good data. But I don't think that the average family medicine physician, internist, or a cardiologist.
They don't have time. Number one,
Right.
with the model that they're in, bless their hearts, they
Right.
just don't have that patient time
Right.
to even support a program like that.
Well, and they're looking at disease. When I say disease state, they are looking at disease state, but it's really, if you're not having symptoms and you're not having obstructive plaque, then most cardiologists are still going to go back to, I'm managing risk factors. If you have a 30% lesion, 40% lesion on an angiogram or a CT angiogram, they're still going to go back to managing risk factors. You're going to go to, let's drive LDL down with a statin. Let's control your blood sugar. We're managing these risk factors, and that's it. We're not doing anything to try to reverse that process, which we have data that we can do in many cases. So they're just not prepped and geared in that way. Most cardiologists are not looking at arterial elasticity, and there's really good data on doing that, but you got to approach it from a different mindset.
So as far as today, this video, the information that we want to get out, anything else that you think that they may need to know, the Rasmussen versus Framingham, looking at understanding disease process, driving cardiovascular disease, not just risk factors. Guys, your blood pressure could be 120/80 or a little bit less, and you
That's
still
right.
have something going on under the surface, but no one's looking. So we need to take into account a whole bunch of other things. So short summary, what are some nuggets? Give us like 5 bullet points. What you got?
So in another study, they looked at traditional cardiovascular disease risk factors. And again, I've got a post about this one on the website as well. Looking at traditional cardiovascular risk factors, and they had in this study that everyone that they had in the study were classified as not having cardiovascular risk factors, and 50% of them, 49%, still had an event. There were even a category of ideal cardiovascular disease risk factors. In other words, your hemoglobin A1C was even less than what they would like to see. Your LDL was less than what we would like to see. You are dialed in, and you can still have an event.
Oh man, so many nuggets today. Got risk factor, disease factors. We've got all kinds of things going on. So guys, be sure, go to our website at revolutionhealth.org so you can access a lot more information about the cardiovascular program and all the research that's been done and articles written to support the information that's been shared. Make sure that you subscribe to this channel, that you like this video, share it. Be sure to share it, guys. We want to get the word out. That's why we're doing this. And then
Comments.
lots and lots of comments. Let us know
What
if
you wanna
you've got questions, what you want to see, and then anything else.
I think that's it. Thanks so much for watching.
Thanks.